Hi, everyone. We'll plan to start in just about a minute. We're giving people time to trickle in from lunch. So hope everyone enjoyed your lunch break. And we know we have a big task to do presentations after lunch. So we have an exciting panel who's going to keep you engaged after your big meals. So we'll just start in a couple seconds. All right, hello everyone. Thank you for attending today's session on medical certification and improving cause of death data. My name is Jaleesa Hinkle, and I'm the Director for Programs at the CDC Foundation, supporting the Data for Health initiative. Shortly, I will introduce each of our speakers, who will then speak for 10 minutes. If there is time, we can have up to 5 minutes of question and answer immediately after each speaker. If not, please hold your questions until the end during our dedicated Q&A panel. And if you do have a question that you'd like to hold for the end, please remember to write it down so you have it. And if you are attending online, please utilize the chat for any questions you may have. We have a great group of presenters, so we'll go ahead and get started. And presenters, if you could just wave when I say your name so people can associate who you are. Our first speaker is Dr. Prasanna Apuhami from the Ministry of Health in Sri Lanka, who will be presenting on how accurate death certificates are for non-specialist doctors, a study of medical legal autopsies in Sri Lanka. Dr. Prasanna Apuhami is a board-certified forensic pathologist and specialist in clinical forensic medicine and is currently based at the Office of the Judicial Medical Officer of Base Hospital in Puttalam, Sri Lanka. He received his medical degree from the Faculty of Medicine of the University of Colombo in 2005 and completed his postgraduate training, earning an MD in forensic medicine in 2016. Dr. Apuhami further developed his expertise through a fellowship at the District 16 Medical Examiner's Office in Marathon, Florida, USA. He has also served as a visiting lecturer in several Sri Lankan universities. His research assesses the quality of cause of death data by investigating errors as reported on autopsy notification forms in Sri Lanka. It aims to identify deficiencies and error patterns to implement targeted training for medical officers lacking specialized education. By validating mortality data, his research seeks to enhance health planning and improve vital statistics systems, ultimately contributing to better public health strategies in Sri Lanka. Our second panelist is Dr. Shivari Mapankar from Tata Memorial Center, who will be presenting on exploring the barriers and facilitators to implementing strategies to strengthen medical certification of cause of death in a tertiary hospital in Mumbai, India. Dr. Shivari Mapankar is a CRVS liaison officer supporting the Data for Health initiative at the Tata Memorial Center in collaboration with the CDC Foundation. Her work involves supporting the medical certification of death, capacity building, CRVS governance, and advocacy. Key achievements include supporting the implementation of the mortality coding system in the Municipal Corporation of Greater Mumbai and leading the mandatory inclusion of MCCD training for doctors in Mumbai. And our final panelist is Mr. Kayla Tawai with the Data for Health Initiative, who will be presenting on understanding common errors made by doctors when completing the medical certificate of cause of death in Papua New Guinea. Mr. Kayla Tawai is an ICD coder with the Data for Health Initiative, supported by the CDC Foundation in Papua New Guinea. His work involves coding, IRIS, and collecting MCCD reports from different provinces within the country. With that, I will hand it over to our first presenter, Dr. Prasanna Apuhami. Thank you.
Good afternoon. Thank you for the introduction. Today, I will present my study titled, How Accurate Are the Cause of Deaths of Non-Specialized Doctors. It's a study of medical legal autopsies in Sri Lanka. This research is part of CRVS Applied Research Training Initiative. I would like to thank UNESCAP, Bloomberg Philanthropies, and Vital Strategies. I also wish to express our gratitude to Nicola Ridget, Nicholas, Petra, Tanya, Liesel, Romain, and Dr. Saman, and the team from the SCAP. Introduction. Accurate reporting of cause of death is essential for reliable national mortality data. Inaccurate death certification can lead to misinformed health policies and hinder medico-legal investigations. Studies have shown that errors in death certificates are common among worldwide, which are completed by doctors. Audits of these certificates can identify common errors, which can improve documentation and strengthen training. In Sri Lanka, medico-legal autopsies are performed by specialist forensic pathologists and non-specialized doctors. These specialists receive structured postgraduate training compared to non-specialized doctors. Few studies have evaluated the accuracy of post-mortem cause of death reporting, especially for certificates completed by non-specialized doctors. To address this gap, the present study aims to evaluate the accuracy of cause of death statements in autopsy notification forms. The aim of this study is to provide evidence-based recommendations to improve certification practice in medical legal service. Methods. We retrospectively reviewed accuracy of cause of death certification on non-specialized doctors at the Institute of Forensic Medicine and Toxicology, Colombo, Sri Lanka. There were 811 death certificates in which autopsy was performed between January 1st to December 31st, 2023. Cases were excluded if the cause of death was pending due to delayed toxicology results or unavailability of post-mortem records. Data was collected include age, sex, place of death, type of inquirer, the cause of death statement recorded in Part 1 and Part 2. Cause of death error was evaluated using University of Melbourne Medical Certificate of Cause of Death Rapid Assessment Tool. Errors were classified as major errors, minor errors, and clerical errors. Major errors were that could change the true underlying cause of death. These include wrong sequence, listing mechanism of death, indicating multiple causes in single line, leaving key details in cancer-related deaths, external causes or poisoning cases. All the other errors were considered as minor, that did not change the true underlying cause of death. Clerical errors were also recorded separately. Underlying cause of death was grouped into 9 categories based on ICD-10. Categories with fewer than 10 cases were combined under Other. Primary outcome variables were the presence of major errors and clerical errors. Independent variables include age, sex, place of death, type of inquirer, ICD-10 category of underlying cause of death. Results. Between January 1st to December 31st, 2023, a total of 2,012 autopsies were conducted at the medical legal unit. Non-specialized doctors performed 811 autopsies, which comprised around 40% of the total. Most deaths were among males, which is 74%. Highest number of deaths occurred between the ages of 45 to 64 years. Median age was 58.5. All autopsy notification forms had at least minor error or major error. All autopsy notification forms had minor errors. Most common error that was not mentioning the time interval of the onset of the condition to the death, which was 100%. Other minor errors included illegible handwriting, 27.6%, not mentioning the place of death, 8.5%. Clerical errors were presented in 14% of autopsy notification forms. Major errors. 50% of death certificate had major errors. The most common major error was missing additional detail in deaths due to external causes, 39%. This was followed by listing secondary or intermediate cause as the underlying cause, 9.8%. Another error was writing multiple causes in line, 6.8%. Deaths due to external causes and malignancies were significantly more likely to have major errors. Deaths due to cardiovascular, respiratory, genitourinary, GIT, and other causes significantly less likely to have minor errors, major errors. Discussion. To our knowledge, this is the first study done in Sri Lanka to assess the accuracy of cause of death statements in this setting. All autopsy notification forms reviewed had at least one error. Many had multiple errors. These findings are similar to international studies and show ongoing problem in death certification by doctors. Autopsy findings are gold standard for checking the accuracy of death certification. In this study, the proportion of major error was high, similar to other studies. However, direct comparison is difficult because different studies use different methods and different definitions. We found major errors in 50% of our autopsy notification forms, while other studies reported rate between 23% and 74%. This study had several limitations. First, it included death certificates from one hospital. Therefore, results cannot be generalized to all settings. The distribution of the underlying cause of death can vary between institutions. This medical legal unit is linked to a neurotrauma unit. Therefore, it receives more trauma cases than other units in the country. As a result, the proportion of external causes listed in the underlying cause is high. Therefore, distribution of underlying cause of death should be considered when interpreting these results. Conclusion. This study found high number of errors in cause of death statements in autopsy notification forms in Colombo, Sri Lanka. All certificates contain at least one error. About half had major errors. Errors were more common in external cause of deaths, often due to missing details. Inaccurate death certification can affect mortality statistics. Improving death certification will help produce more reliable mortality data, support better health policies in Sri Lanka. Thank you for your time and attention. If you have any questions, I'm happy to open up for the discussion.
Thank you, Dr. Prasanna. We have time for a few questions. Anyone in the group have a question? Yes, go ahead.
Thank you. Give me the opportunity to ask the question. I am Husnaira Parveen from Bangladesh. I'm working at Ministry of Health. Actually, my academic work was evaluation of the medical certification of cause of death from 2020 to 2024. Then I use the software Anaconda. Do you know this or aware about it? And they are use ICD code 10, and now we are planning to take ICD code 11. We are piloting somewhere. In the next year, we will do that, implement ICD code 11. Have you any plan for Sri Lanka ICD code 11? And another question, for my inquiry or interest, do you have all of dead body take post-mortem facilities, or your presentation in our Bangladesh only for legal purpose we are doing post-mortem, not for all? Do you have the opportunity for all, or only the illegal purpose? Thank you.
Yes. There were three questions. Yes, I used University of Melbourne cause of death assessment tool, and I know about these softwares, but this is a limited study, so I use that method. The reason for me choosing ICD-10 is that was in 2023. So the ICD-11 became effective slightly later. And about autopsies, I think in many countries the system is the same. If there is a doctor who treats the patient, and if the patient dies, the doctor will give a medical certificate of cause of death. If there is no doctor, or if it is due to unnatural causes, there will be an inquest, and even in inquest, all will not end up in autopsy. Some of them will be certified by the coroner, and there are certain indications for autopsies, so we get only on those cases, like we have a circular developed by the Ministry of Justice where unnatural deaths, maternal deaths, and there are some indications where we do autopsies.
Thank you.
Okay, thank you.
Okay, thank you for the presentation. I'm from Ministry of Health in Cameroon, and we are actually working on implementation of medical certification, and at least data quality is a real issue. So your study is very nice to us. I would like to know, have you globally evaluated, because there is one indicator usually addressed for the quality is the percentage of ill-defined cause. So globally, have you been able to determine that proportion of ill-defined cause? And secondly, I would like to know, is there any study in your country that evaluates, like you are in the autopsy, I think generally is the foreignist scientists that are the specialist doctor that used to make the autopsy. So how is there any study evaluating the quality when it's the autopsy, the certification have been made by a specialist? Because now you see the non-specialist, but we cannot know. It's true that it's not a comparative study, but as you targeted the non-specialist, the natural question is, how about the specialist? How about the foreign scientist? Thank you.
I think I did this study only using non-specialist doctors, was also to teach our specialist. My main goal was that, I will give you a small example. In a road traffic trauma, when somebody's head is hit against a vehicle, we write the cause of death as head injury due to blunt trauma. But really, underlying cause of death is the circumstance. So we should write road traffic injury. In this study, 98% did not write road traffic injury. They stopped at blunt force trauma. There is a reason. Now, in medical legal practice, you have to say if you know it. For an example, if there are some abrasions and contusion, if there are skull fractures, we cannot sometimes differentiate whether it's due to road traffic injury or whether it's due to an assault, when there is lack of circumstance, when there is lack of police information, when there is no eyewitnesses. So the general trend is to write blunt impact trauma and just forget it. Now the teaching is we can write possible road traffic injury. Instead of stopping at blunt impact trauma, we could write head injury due to blunt trauma, possible road traffic injury, so that the coders would have better cause of death for their part. So that is what I wanted to give this information, not only to non-specialized doctors, but to the specialists who had been practicing the same way. So that is my main objective. So there is a way of teaching people by showing that non-trained doctors are doing this mistake. So if this is seen by a trained doctor or a specialist, he would also read something about it and he would improve the system. That is my objective.
All right, great, thank you. That's really interesting, and that probably has led to some questions we might have later in the session. Now we will transition over to Dr. Shivari Mapankar for her presentation.
Thank you.
Merci beaucoup. Bon après-midi à toutes et à tous et salutations pour ma présentation donc sur les obstacles je fais partie ma présentation ça va être d'explorer vraiment les obstacles et les facteurs facilitant la mise en œuvre de stratégies pour renforcer la certification médicale des causes de décès. Voilà, je voudrais parler déjà de cette image que nous avons. Vous pouvez voir ici, c'est dans une ville d'Inde, donc, qui est l'une des villes les plus sacrées d'Inde. Vous pouvez voir que la mort, c'est culturellement quelque chose d'assez accepté au sein de notre système culturel et religieux, et c'est en tant que plutôt transition, plutôt qu'un point final. Donc, c'est pour cela que pour tous les programmes, qu'ils soient grands ou petits, qui visent à renforcer les données des causes mortuaires, c'est très important de garder ça à l'esprit. Bon, bien sûr, on peut voir la session. Il faut avoir une bonne compréhension déjà de quel type de données on a besoin et pourquoi c'est tellement important d'avoir des données. Bien sûr, on sait que c'est important pour mesurer les progrès des objectifs de développement durable. Mais ceci étant dit, pour les data au niveau macro, il faut des initiatives à fort investissement telles que la macro-formation à grande échelle, le Data for Health de Bloomberg, les philanthropies, qui permettent de réduire les erreurs entre 15 et 33%. Ensuite, au niveau médian, il y a des projets pilotes régionaux qui mobilisent vraiment des agents de sécurité communautaires pour les autopsies verbales, mais vraiment, qu'est-ce qui se passe vraiment au niveau sur le terrain, en fait? Il y a beaucoup d'initiatives et de programmes qui ont été mis en place et se concentrer sur les erreurs qui ont été faites par les médecins. Mais il est temps pour nous maintenant d'aller au-delà de simplement la formation de docteurs. De toutes les morts qui sont enregistrées en Inde de façon annuelle, et il y a à peu près seulement 23% qui sont certifiés médicaments. Donc il faut vraiment comprendre, il y a combien de... On comprend les personnes qui meurent, mais on ne comprend pas pourquoi elles meurent. Donc c'est vraiment notre problème principal. Hein. Il y a des goulots d'étranglement. L'étude que l'on a menée a 3 objectifs. Tout d'abord, il faut comprendre les facteurs influençant la certification médicale des causes de décès dans un hôpital tertiaire à Mumbai. Il faut aussi il faut documenter les perceptions des principales parties prenantes à l'égard de la certification médicale des causes de décès dans un hôpital tertiaire. Et il faut aussi décomposer ces perceptions à l'aide de lignes directrices du CEPS. Donc la méthode de recherche, donc ça a été fait à Mumbai, centre de traitement avancé. Donc il y a eu trois choses principales. Les données ont été capturées en conduisant à des entretiens semi-structurés avec 30 parties prenantes différentes. Ensuite, c'est divisé en deux groupes. On va déconstruire les données. Tout d'abord, il y a l'administration et les dirigeants. Il y a un terme de gouvernance. Direction, administration de l'hôpital. Pour la gestion des données, il y a le personnel.
Data analysts, doctors, and nurses as well. It will also be made sure that equal number of participants are included from each of the groups to avoid any hierarchical bias. The interview guides have been prepared. The responses that would be recorded would be transcribed verbatim and further processed. A deductive coding approach would be followed based on the domains of the CEPS model. The Systems Engineering Initiative for Patient Safety, or CEPS, shifts the focus from isolated doctor error to interacting work system elements. The CEPS model is further broken down into three domains. The first domain is work system, which is subdivided into person, organization, technologies and tools, and tasks and environment. The next domain is processes, and the third domain is outcome that involve both the employee or organizational level outcome as well as patient level outcomes. The expected results of the study would focus on three important levels of improvement. At the micro level, the physician's cognitive load. At the time of a patient's death, the physician's capacity to perfectly and execute MCCD could be compromised by competing vectors of immediate stress. At a mid-level, which is the workforce ecosystem, the physical and technological environments frequently sabotage the documentation process. And a standardized MCCD forms becomes into an administrative hurdle. At the macro level, which is the organizational accountability, individual training dissipates rapidly if the organizational culture does not mandate, measure, or reward accurate cause of death reporting. To conclude, I think we need to have a systems approach to improve cause of death data, since its ultimate beneficiary are the patients living or deceased. This kind of qualitative research and subsequent models developed could look at bridging the gap between local clinical realities and macro-level SDG surveillance at the level of policymakers. One of the limitations of this study, though, that is, it only focuses on medical certification of cause of death, or MCCD. In a hospital setup, other sources of cause of death data are medical legal deaths or brought dead cases as well. Similar methodology could be reproduced to develop robust SOPs for these phenomena as well. Also, it could be worthwhile to consider the perceptions of the relatives of the deceased or the next of kin through the interviews. Due to time constraint, I was not able to capture those. I would like to express my sincere gratitude towards the leadership at the Tata Memorial Center for allowing me to carry out this study and also guiding me through the course of its time. A big thank you to Liesel, my CART mentor, and my colleagues at the Unit for Strengthening Cause of Death. Conducting research, of course, requires a lot of backing in terms of resources, so a thank you to the CDC Foundation and the Bloomberg Philanthropies Data for Health Initiative. Last but certainly not the least, thank you to UNSCAP and UNECA for giving me the opportunity to be a part of the CART initiative and to be a proud Cartisan, as we fondly call ourselves. I am open for questions. But before questions from the audience, I would like to leave us all with one. Can we really make every death count without taking into account the people involved in counting all the deaths? Thank you.
Great, thank you, Dr. Shivari. And you did great on time, so we have plenty of time for questions. And I really liked the conclusion that you had about the end beneficiary, and considering that the ultimate beneficiary of accurate cause of death information is the patient living as well as the deceased. Are there any questions from the audience?
Thank you very much, Dr. Sarvari, for this wonderful presentation. I actually wanted to know if I might go beyond the, your research objectives, but I just wanted to know if there are any specific laws in Nepal, specific laws in India that addresses such mistakes, or as you mentioned, the administrative hurdles that are created by the hospital administration or doctors or any medical personnel in hospital. Thank you very much.
Thank you for the question. India has, at the national level, the Registration of Births and Deaths Act of 1969. Although the act is implemented at the national level, the states have into their power to implement the law. A lot of times, guidelines are placed out and government orders are placed out, but really at the end user level, which is the ones at working on the ground level, physicians are often not taken into account while these laws are being implemented, which is the challenge. And through our work as a part of Data for Health, we've been able to speak with a lot of the end users, physicians, hospital administrators, and it is a challenge on their end to implement these kind of laws. But absolutely, there is a national law that we have. Thank you.
Thank you.
Okay, great. Are there any other questions? Yes, please.
Thank you for a great presentation, as always. So what I wanted to ask you, that I understand that you are still in the process and probably you cannot share the data at this stage, but what are the barriers that you foresee or you actually saw in the field by conducting this research? Because it is difficult to see micro as a separate component, because you have to take into account the macro factors as well. So if you could just throw a few words on that. Thank you.
Sure. Let me share with you a case scenario that we've faced. Doctors were trained rigorously, and this included doctors at the junior most level who are often responsible for filling the MCCD forms. And even after the training, we observed that the quality of MCCD forms that were filled by them still had a lot of the errors, perhaps a few more errors happening post the training. We dug a little bit deep into that, and we understood from the perceptions that they shared is there are administrative personnel who act as checkpoints for the final signing off of the MCCD certificates. And it was seen that those were not taken into account during the training, only doctors were trained. So the administrative personnel were aware of the older practices and not the newer and more standard practices. And they were asking the doctors to, this is not right, please go rectify and then go back to the older practices. That was a hurdle. So often while designing training programs, if we only involve the doctors and train them in a classroom, that will not be sufficient, is one of the feedbacks. We also see a lot of times culturally, the relatives or the next of kin, it is a very chaotic scenario, especially in tertiary hospitals back home. They are in a rush. They want to take away the body. There is no waiting time between taking the body back home and disposal, which is why there is a lot of pressure on the doctor to hurry up and rush the process of cause of death certification, which is one factor which may not be taken into account when a doctor is, taught how to certify causes of death. These were just few, but I'm, very much open. I can discuss a few more with you. Thank you.
All right, great. Given I don't see any hands raised, would you mind sharing a few more of those results that you experienced, Dr. Shivari?
Sure. When doctors are trained in cause of death certification through our training programs, we've also observed a lot of reluctance within them to further cascade the training programs to newer doctors. And there is a lot of attrition of doctors, newly joining doctors, or transfers and so on and so forth that happens in India. So the knowledge really remains with the one that gets trained as a one-off training and does not cascade further. And the reason why these cascading programs do not happen is, one, lack of resources that they outline, and also because back home in India, there is always a requirement for administrative letters that are supposed to be issued to the doctors in order for them to carry out the trainings. If no letters are issued, the training will remain with them and not go further, which is also one of the hurdles.
All right, wonderful. And I think something that's been really great about the forum and the various sessions is seeing how much all of these different topics and all of the different studies connect to each other. So we had a presentation on death registration before lunch, and that was a similar issue identified of having turnover with staff or new doctors coming in and not being trained. So it's great to see the connection with Dr. Mena Mateo's presentation on Cook Islands as well. Any final questions or comments before we move on? Okay, then I'll hand it over.
Thank you. Witness my presentation. I'd like to thank you all for coming. This afternoon, I will be presenting especially on a one-pager form, which is MCDO. And I believe this afternoon, as we sit around here, we know this form very well. Though it's only one-pager, it has a lot of valuable information. You know, if you want to see someone who certify the disease, this form can help you. This form will help you, especially on the certifier's position. Yeah. So from that, I began to come up with, because right now as I speak, I believe we have in the hospital, doctors are filling out this form, especially for someone who has died. That's the reason why. And my concern is whether they are filling this form correctly or not. That's the reason why I began to get this research topic to identify the most common errors in medical causes of death, MCCOD, in Papua New Guinea, and propose target intervention to reduce these errors among trained medical officers. But before I continue, I want to acknowledge my special thanks to the United Nations Economic Commission for Africa, ECA, and also Economics and Social Commission for Asia and the Pacific, ESCAP, and the 2025 Civil Registry and Vital Statistics Applied CART, especially for the initiative, particularly to my mentors, Thomas, Nicholas, and everybody for your guidance and support throughout the research process. My introduction is accurate cause of death is essential for effective public health planning and resource allocation. Very important. When you have the accurate data, you can plan and carry out. And you can resource. So in Papua New Guinea, before the D4HI, or Data for Health Initiative, medical certificate of causes of death, MCCOD, forms were often completed incorrectly due to no MCCD training of physicians in PNG. This reduced MCCO errors by 30%. Lack of understanding, lack of standardized procedures for QA or quarterly assessment, and systemic challenges in health information infrastructure. This is a study by the University of Melbourne found that direct. Through D4H, Data for Health, over 350 doctors, medical students, and health extension officers have an MCCD training since 2018. 100% of these medical schools have cadre of academics trained as master's trainers, training adopted with plans to institutionalize e-learning MCCD training. Research method, there was a selected MCCODs were collected from pre and post MCC training from provincial hospital and analyzed using the University of Melbourne MCCD quality assessment tool. This provided a structure measure of the most common errors. The variables measured where we have multiple causes per line, the missing time intervals, use of abbreviations, illegible handwriting, incorrect sequencing, external cost details, neoplasia details. And those are the results I've just shown by the category. You have the number of provinces, about 9 of them, and the province's name with the category of excellent, good, and poor. And that's the graph showing of this MCCO DRS. The discussion is the initial hypothesis was that MCCO DRS in PNG stem primarily from inadequate training and systemic gaps in health information infrastructure. The results support this, showing that provinces with target training interventions had significantly fewer errors compared to those without such programs. Data for health efforts to strengthen this system. 1, addressing the training gaps. This is to cater of MCCD trainers training proper certification practices in 2024, with training cascaded to 70% of all provinces from 2025. And we will reach that 90% by March 2027, next year. Master trainers train 400% of medical schools with MCCD training as a mandatory requirement. Number 2, system gaps in health information infrastructure. All MCCD are completed using paper forms, which then need to be scanned, encrypted with a passcode and email. We have a number of hospitals with scanners, and in fact, some of the provinces do not have scanners. So for those people, hospitals who do not have scanners, we don't receive MCCODs from them. Yet, to implement international MCCD, form awaiting finalization of the regulations, although new CR Act passed in November 2024. Current form does not capture manner of death. That's due to surgical complications and more. Master trainers train for 100% of medical schools with MCD training made a mandatory requirement for all medical students and HEO students. Recommendation and next step forward is to integrate international MCCD form into the ENHIs for real-time monitoring to promote accountability and establish mechanisms for auditing and feedback. University medical colleges to embed MCCD modules in medical education. Propose to adopt WHO MCCD tools. MCC training as a SIM requirement biannually for doctors and HEOs through the PNG Medical Board. Lastly, but not the least, integration of MCC audits into routine hospital quarterly processes through the Mortality Committee. Thank you.
Great, thank you, Mr. Kela. Are there any questions from the group? While we're waiting for questions, I wonder if you could go back to the table of results by province. And you can tell that there's varying levels, and a few provinces stick out as being excellent and some as good. Is that due to targeted interventions, or can you talk a little bit more about this table?
Yeah, well, this is MCCD reports that I gathered and entered into the Melbourne. And then this is the scores by category: excellent, good, and poor came about.
Okay, yeah. Okay. Yes, and then in the categories were more excellent. Do you know were there targeted interventions in those hospitals?
So if you look at the Blue colored, we have excellent. And brown color, would good and poor. And we are targeting the poor reporting, especially those of the poor performance provinces we are looking at now, especially to train doctors who are from these provinces, And then it's best to train them so that their performance
Okay,
goes
great.
up.
Thank you. So this is helping to identify future trainings as well.
That's right.
Okay, wonderful. Other questions or comments? Yes.
Merci.
Thank you. You've talked about the collect of information on doctors on the cause of death. Is it possible to insert curriculum on the training for the medical doctor? The other question is to know if there is some feedback on the cause of death. Is the cause known? To know what is the cause of death? Do we have information? Do you have some feedback from the doctor? Do we know so that we know what where we are?
Hospitals after the training, but still we face problem. I don't know why, but it could be the doctors who are trained, who never disseminate what has been trained. That I wouldn't know much, because if we train people and they don't produce what's the result, these are questions that we have to take on. With the causes of death, there's feedbacks given to the hospital of how many deaths happening within the hospital. Yeah.
I can answer about my study. After my study, I gave them a feedback, especially about external causes, and it was kind of a post-study review, and it made several changes to our cause of deaths also, but I did not assess during my CARD program. But by training has, I think that is the best effect if you are going to improve the death certification, that is the training.
Okay, great. Thank you. Nicholas?
Yes, thank you. So we have some online questions from Rohina Joshi. One of the questions, and I believe Prasanna previously addressed parts of it, but maybe you want to further comment on this, is were the non-specialist MCCDs checked against one of the specialists? If so, what was the result for the specialists? So if you want to further comment on that. And Rohina also had a questions for India and PNG. So could both of you clarify the percentage of MCCDs that your results reflect? Thank you.
As I said earlier, I did not compare the specialist with the non-specialist doctors, but I wanted to give the message in an indirect way so that without hurting them, so that they could change. That was my idea. There is a way of, giving a feedback. You can give a feedback without hurting them also. That was my objective. So I didn't check the specialist doctor's errors. And I think, and that is my hypothesis and my gut feeling, and there will be errors, that's for sure.
Yeah, for the percentage of MCCD, just to clarify, so mine is a qualitative study and it does not involve analyzing or assessing the actual MCCD forms.
Mine was 811 autopsy notification forms. Out of those, there were 50% had major errors.
And for PNG, Kayla? Could you please turn on your mic, please?
My results is only showing the categories by excellent, good, and poor. But individual results, perhaps when I get back home, I can work on it. Yeah.
Yes. Thank you.
Okay, thank you for the presentations. My question is for all presenters. There is a tendency of medical doctors to deal with persons who are still alive instead of going to the certification. They are still interested to deal with persons who are alive instead of going to the medical certification. Once you tell them to certify or to do it correctly, they tell you, we are still dealing with people that are alive. You go and deal with those who are dead. How, as researchers, are proposing the solution to that trend that is available, that is there? Thank you.
Thank you for your question, and this is something that one of our field observations has also marked, their reluctance in dealing with end-of-life scenario because it is also chaotic, and more so focusing on the patient that is newly in. For this, we also involve the nursing staff. So nursing staff are the monitoring checkpoints, and they are the ones who are responsible to, we understand that doctors are extremely busy with new patients coming in. The nurses are the ones who fetch after the doctor with the forms just to reduce that administrative burden on them and make sure that the forms are filled in a timely manner. That's one checkpoint, the nurses.
And another thing that I think she had touched also, in hospitals, the junior most doctor, we call it interns, and they are the ones who usually fill this medical certificate of cause of death. Really speaking, according to Birth and Death Registration Act, a doctor who is registered in Sri Lanka, and I think it must be to the whole world, a doctor who is registered could sign a death certificate. So intern is not registered unless he completes his internship, then he will be registered in Sri Lanka Medical Council, and it will be in other countries too. So that is the practical scenario. So, I mean, some other things that I have noticed is even the next level of doctors, we call it senior house officers, they are also not trained, or they are trained because some of them may have gone to medical school 20, 30 years ago, so they lack training. And if you go to the other level, the consultant or the specialist, they may also has had not proper training. So that is the, real truth about this medical certificate of cause of death training,
Thank you for the speakers. I just wonder that data quality related to the causes of mortality has always been very emphasized. And I wonder whether you know to what extent about these ill-defined cases on the mortality list in your countries. Because some countries went up to 20%, 30%, which was quite high. And also the doctors themselves, I think this is the mandatory to put the diagnosis, you see. And I remember a long time ago when I was doing the medical audit for these medical records, patients' records, we came across doctor putting diagnosis as hit by a coconut, fell down from the chair, you know. All this, all these are not diagnosis. So I think very important that they should also be trained to handle medical things, you know, classification of diseases. Because in medical graduates, undergraduates, that time, their exposure is very limited, you know. So normally when we do training for ICT-10, we roam them in, the doctors and the medical quotas all together. I think this need to be done. You want to improve the data quality on mortality statistics. Thank you.
All right, great. Any thoughts from the panel on ill-defined cases and ICD-10 as well as data quality?
Yeah, I think if you go back to my map, you could see the ill-defined. Can you show me the last slide of my presentation? I mean, I can't go. So it shows the world map and the number of ill-defined cause of deaths. In Sri Lanka, it's about 30%. And if you look at most of the Asian countries, it is, no, map somewhere, somewhere after that. I had a map. I showed a map. No, I showed a map. I think that shows, it was a study done in 2015, and it shows the ill-defined causes, and in Sri Lanka it was about 30, and most of these Asian countries it was the same, and I think some of the data is not available in African countries, and it is quietly high ill-defined causes. Now this is the one here. This is called, they are called garbage codes, and you could see Sri Lanka is marked red, orange in color, so it is 25 to 29%, and you could see there are many countries, there is no data on many countries, and you could see the ill-defined causes in other countries too. And one thing we have to know, I must say now, when we say errors in death certification, I will give you a small example. Out of the autopsies that we do, 10% of the autopsies we will not have a cause of death. Because based on the investigation that we have, we will not have cause of death. For an example, there are some diseases in the heart, we call it channelopathies. There are electrical currents that go in the heart. There are congenital diseases that can cause arrhythmias, the heart to stop. So there are no methods of diagnosing some of these. So that in those cases, we may not be able to give a cause of death, and we give as unascertained. So that becomes an ill-defined. So there will be now more, not all the errors are due to their, lack of knowledge. There are, like for an example, if a country does not have the sophisticated toxicology, we may miss certain findings. So if you do not have the sophisticated, the newer technology, we will miss. So these errors are not really due to lack of knowledge also. One thing the non-medical people should know is when we say errors, some of them are due to, systemic things, the deficiency of the, investigations. For an example, I would give a small example. If during winter, if somebody goes out and stay about 5-6 hours, they would die of hypothermia. And in hypothermia, there are no autopsy findings. So if there is no circumstantial evidence, we would give as unascertained. And there is no cause of death in that circumstance, So you will have to know, when we say unascertained, that does not mean this doctor did not have a knowledge, things like that. So there are many things that you will have to look into when we say, identifying the proper cause of death also.
Okay, I think we had a question up in the front in the blue, and then we can go over to the gentleman in the red.
Okay, thank you. I would like to have the experience of the country about the implication of the medical, I don't know in English, council, because to read the other medical, yes, because is there any certification or license that medical doctors have to renew regularly to maintain the right to exerce, and if so, are the council implicated in the certification? Is it integrated inside? Thank you.
Yeah, thank you for your question. I'd like to take that. In India, we do have the National Medical Council, that is the regulatory body for all the certified practitioners, for modern medicine practitioners. Alongside, we also have alternative medicine doctors, which practice not modern medicine, but Ayurveda, Unani, etc., which also have a separate body. So what we are trying to do is through the commissions, try to get e-learning mandatory at the national level, at the level of medical internship. So before a doctor passes out, after completing their medical degree, they are well prepared to take on or certify MCCDs. Another example is, and this would be mandatory in terms of completion of their internship. The medical internship would require them to solve a given number of cases. We have designed a case scenario workbook, which has around 200 case scenarios, and they have to solve the workbook in order for their internship completion. This is still in the works. What we've done in the city of Mumbai, which is one city in India, but it has around 100,000 annual deaths. For private practitioners, we have made the MCCD e-learning course mandatory. So when they have to collect the physical copies of the blank MCCD forms, they are required to produce the certificate of completion of the MCCD e-learning course. And this has shown remarkable outreach in terms of covering the vast number of private practitioners. Yeah. These are two interventions that we've taken place. Thank you.
Thank you, Dr. Shivari. Are there examples related to Sri Lanka or Papua New Guinea where doctors are required to get recertified, and is this built in the medical certification of cause of death training?
Yeah, during their medical school curriculum, there is a medical legal module where they are taught of death certification, and they will have exams, continuous assessments, and they will be assessed. Once they have passed the MBBS, there won't be certification exams, but usually they will have continuous professional development, lectures, workshops, and things like that. But what we have found is there is general lack of enthusiasm among them, mainly due to work-related issues. You know, when we organize workshops, even when I go to a new, we are transferred every 4 years as specialists. So whenever I see issues, I voluntarily organize workshops for them, and there is lack of participation, to be frank. Probably work-related, you know, say if we are organizing a lecture around 11 o'clock, if they are in a clinic, you know, not all will be able to come. So there are a lot of practical issues too, you know. Now even we may conduct, you know, we may produce, you know, documents, you know, we may produce handbooks and things like that, you know. So depends on, you know, even we will have to assess based on evidence how effective those methods are, you know. So if there is a lack of interest, you know, there will be, you know, issues on the effect also.
From Papua New Guinea, we have this experience of training MCCD trainers, but the way we look at the data, there's still inconsistency. I don't know why, but maybe those doctors who are coming, the movement of doctors moving in and out is one thing, because some do not been trained. And especially for doctors who are trained, it would be best if they can impart the skill to those who are working with them. And then this knowledge or skill can continue. Yeah, that's what I'm trying to say. Yeah, thank you.
All right, great, thank you. So various examples related to continuing medical education. We'll go to our question in the front.
Merci.
Thank you very much. First, I would like to congratulate all the presentator. And I really like the first presentation concerning what you mentioned. There is a table when you can see the minor errors. So there is something that struck my attention. I'm sorry, as a professional, I'm a statistician, so I can see some minor mistake. I can see that the time between the disease and the cause of death, it's not mentioned in 100% of the certificate. So maybe some variable is missing there. For this type of information, I have seen that, for example, the place of residency of the deceased, it's not showing. Maybe it's important, maybe it's not. But do we need these elements or not concerning the domiciliation of the death? For example, for the mortality rate, we need to mention where was the disease, that can, regardless if it's in a village or in the city. So I was wondering if you had, like, on your form, do you have any other style or no types of variables? And when it comes to the intervals issue, what are when we talk about in verbal autopsy, we can have the information, but on this form, can you reach the same level as a verbal autopsy? Thank you very much.
An interesting question. Now, if you look at the last line, time interval between onset of condition and death, not mentioned in part 1. Now, if you look at the medical certificate of cause of death, there are 3 parts, part 1, part 2, and the time interval. Doctors, if you look at studies, this is the result. 98% or 100%, they have not written the time interval. The thing is, I think probably the reason is they think, what you need if he died of heart disease, heart attack. Why do you want that? That is their thinking, This is the trend. If you look at the studies, this is not exaggerated results, 100% in my study, they have not mentioned time interval. This is not exaggeration, or this is not a mistake. And if you look at the previous studies also, up to around 98 to 100%, they have not mentioned the time interval. This is a trend. This is what's happening, because doctors have, probably got an idea. What you need is a cause of death. Why do you want the time interval? That is my impression. That is the real situation. This is not any mistake or error on my part of data collection.
About that, what is the recommendation about this situation? What do you recommend?
Yeah, again, teaching them, now there are few benefits of writing the time interval. For an example, if a doctor makes an error in writing the cause of death, if you write the time interval correctly, the coder could change that. Sometimes you may write 1B in 1C. But if you write the time interval correctly, then the coder would understand, there is a mistake, and he could correct it. When mistakes occur, there are levels of correction. Even at coders level, they could do some correction. So, this is very important. Doctors need to write, and I have started teaching to medical students and postgraduate students. I present my research findings to them. when I teach, we have to show them, if there are errors, you have to show them. Since I think probably this is the only study available in Sri Lanka, and I think even I have not seen studies now. This is, we looking for our errors, we tend not to look at our errors, whereas I had done it. So, I mean, this is a good study to show, we are making, I may have made it, to be frank. I may have made it maybe some years ago, to be frank. So with this research, I learn a lot about civil registration and vital statistics, especially the importance. We as doctors, my general knowledge is, we have not found out the real value of this cause of death. That is the reason for these errors. If we had known, we would have spent time on this. And I don't know whether you all know that in England, there is a system called medical examiner. Whatever the cause you give, it will go to the medical examiner. And if they think there is an error, they will bring the medical document and they will cross-check it. If there is an error, they would send the cause of death form back to the doctor and to correct it. I think it is kind of a review, but it is, it is strict. I think that is the only system that I have seen. Or else we should start reviewing our own cause of deaths through the hospital, maybe kind of a, the clinicians, the director, and maybe the pathologists getting involved, reviewing our own cause of death, which doesn't happen.
All right, great. I think Dr. Shivari, did you also want to respond?
Yes, thank you. We resonate with the findings of Dr. Prasanna. In the kind of analysis that we've done in different studies, we have seen that 100% of the forms, or close to 100%, have the time of onset or time interval missing. Through our trainings, we have also learned that doctors, junior doctors especially, they just don't know what is supposed to be entered in that column. Sometimes they are also filling time of death or time of admission if it is an institutional death. The recommendation for this, again, we have made them aware of the importance in terms of if while writing the sequence of causes of death, there is an error on the part of the doctor, at least if they enter the time interval, the coder will be able to pick up, or where sophisticated systems like maybe an automated coding system is available, the software will be still able to pick up the underlying cause. This is one. We have trained the nurses in these variables to be a checkpoint. So before the form goes off to the medical records department, nurses just check. Nurses cannot interfere with the actual causes of death because then it also hampers, sometimes doctors don't like the nurses pointing out at the cause of death sequence, but they are okay with the nurse just reminding them about the time of interval is missing or onset is missing. They will make an attempt to at least mention something, if not anything. We also suggest to them that maybe there is no hard and fast rule that you put an absolute figure, 20 years, 10 years. We encourage them at least enter the words, years, months, or minutes, or seconds, or few hours, few minutes. Sometimes for the immediate cause, they are not aware of what to put because it's an estimation. So this is how we go about our trainings, and we have also designed hospital-level SOPs which have 10 pointers. These are 10 do's and don'ts. They only have to follow them, which makes their life a little bit easier. They don't have to do a lot of guesswork, but these are flyers that we've designed. We put it at the nursing station or where the medical officer sits. We put it on their desk, and they just have to follow those. Thank you.
All right, great. I see a question in the front. Thank you.
Yes, thank you, Madam. Please, I would like to address my question to the last presenter, and it concerns the page on results. Table 1, it concerns the results, the first page. It seems as there may be a mistake in the figures presented there. The figures are presented into percentages. And normally, if you want to check out, you must sum up per line. In each line, you must have the sum of which is 100. And there are many lines there which are not up to 100. There are even some which are more than 100. Line 9, for example, it is less than 100. Line 3 is not up to 100. There is even a line there which is 103. Line 4. Line 4 is not up to 100. And line 6 is more than 100. That is one question which we would like to understand why. And we also would like to understand why you have put a star on some of the modalities of some of the provinces there.
Good. Why there are stars beside these provinces? Because these are the provinces MCCD trainings have been conducted. And others, I didn't put them because they were all also trained, but from these 9, there were 2 provinces which were not trained, and I think that's Hela and Jiwaka. Yeah. But on the other question, the first question, I made a sampling of 100 MCCDs and putting it to the Melbourne MCCD assessment, and that's the result that I got, especially on the category part of it.
Okay, so those percentages are what came out of the Melbourne tool.
Yeah.
Okay, thank you. Okay, Nicholas.
So we have an online question from Mohammed Selim Reza from Bangladesh, and his question is for all speakers. And it is, how can countries leverage digital tools, platforms, or digital integration with health systems to strengthen CRVS system and improve the timeliness and accuracy of MCCDs?
I can try. We don't know the absolute best practices, otherwise our country would have been 100% MCCD. But one idea that we've been discussing is how AI can be used to prompt a doctor filling eMCCD. That would of course not work with physical MCCD forms. Maybe eMCCD, how AI can prompt the doctor filling as to, okay, if cardiac arrest is filled as an underlying cause, which is not the underlying cause, it will prompt. And then they can, rectify. Also, maybe tools such as perhaps Iris or any other that gives automated coding could be incorporated into hospital EMRs, where doctors can fill the MCCD digitally, and the coding also pops up. If it's not the right code as per the cause, so if it's a wrong ICD code for the underlying cause, it will pop up, and then maybe perhaps these are just ideas that we could take up as maybe pilot research topics and then see how it goes.
I think Sri Lanka made an app. If Maya was there, he could have enlightened more about it. We developed an app, so that that would improve the cause of death. Like, if somebody, really speaking, you can't even write cardiorespiratory arrest as an immediate cause of death. So forget about underlying cause, even as an immediate cause of death, you can't, those are mechanisms, so, I mean, those are the newer things that can be used so that, even maybe due to lack of knowledge or due to increased workload, that would automatically, remove some of these errors that would, give a drastic response to drastic improvement to our accuracy and quality of cause of death. Those things has to be used because nowadays, AI is just a simple, tech.
Mr. Kayla, did you have anything you want to add? No? Okay. Yes, I know we all get excited thinking about AI and artificial intelligence and how it can support our work. That's a good reminder about IRIS and existing automated coding tools. Are there any other questions? We have about 5 minutes left in the session. Yes.
Hi, good afternoon. I'm Marco from the Philippines. I'm a local civil registrar. Thank you for your presentation. Since we already identified, based on your research, that errors do exist in the certificates of death, and there's a process of correcting those, I just wonder how difficult the process of correction these errors, particularly on the causes of death, in your country is. For context, in the Philippines, if we will correct cause of death, it requires court order. And 2 weeks ago, I registered a death certificate in my office, and the cause of death was heart attack. 2 days after, the family ordered an autopsy, and they found out that the disease has skull fracture. So he was a victim of a crime. So they wanted me to change the registered death certificate, and I cannot do so without a court order. So that's why I ask how easy or difficult the process is in your country.
Yeah, I will give a small, now there is a system error in your system. For an example, if a patient dies in the ward, say after an assault, he is hospitalized, they have done a CT, they have done a surgery, but he dies. Even in those, the doctors can't write the cause of death. That goes for an autopsy. So we write the cause of death. So there is no repetition, or, I think that has to be changed through a system so that we don't need to, worry about, because I don't know, for an example, a person may come to the ward, the relatives might bring him saying he was found fallen. And outside, you may not find injuries. When you do the autopsy, you will find skull fractures. So the ward doctor may not know. So we, after the autopsy, we write the proper cause of death. So I think in Sri Lanka, if it is a doctor who certifies, if it is a natural death, he writes it. If it is an inquest, the coroner writes it. If it is an autopsy, we write it. So there is no repetition, or there is no, 2 people writing on the same person. I think that system needs to be changed, with a way. For an example, I would like to tell you about, we do something called second autopsies. For an example, a person may die of, say, natural death, in the ward, they would give a cause of death. But later on, relatives would come and say, no, we are not happy with that, we won't. They get a court order, we exhume the body, we do the autopsy, and you get a new cause of death. Then legally, there is a provision to write it. You don't need to get a because the body is, retrieved, and the magistrate has given a cause of death, the magistrate had given an order, so we give a newer cause of death. That's legal. I think in there should be a way, so that if an autopsy is done, the medical doctor should not, there should be a way of saying, you can't give a cause of death because this will go to an autopsy, so that, there will be conflicting cause of deaths,
Thank you.
All right, great. I think we're right at time. So maybe we can give our panelists another round of applause. Thank you so much for your presentations. And we all know that accurate cause of death data and information is extremely important as we look to public health planning and figuring out how we can best support the people in the countries where we live. So I heard examples of recommendations related to trainings and ensuring we're using international forms to support the work that's being done and support our frontline workers and those who are completing our MCCD forms. If you're interested in continuing the conversation related to medical certification, we're going to have a coffee break right now, but there'll be another session related to medical certification in this room right after our coffee break. So now we will break. Coffee will be right in front of the room that we're in now, and the next session will begin at 2:45. Thank you all.